My name is Dr. Alan Matarasso. I will be discussing correction of gynecomastia in bodybuilders. When examining the bodybuilder patient, you're dealing with a person that has low body fat, a perfectionist type of individual in terms of their expectations. A couple of points should be made. They should be examined in the same way a standard patient would be, that is to make sure they're not taking any medications or using any products that would cause gynecomastia, and there are no hormonal imbalances. Furthermore, you must be aware that the anabolic steroids can cause breast growth, and they should be off anabolic steroids for a period of time because that can contribute to the gynecomastia, so that you're dealing with a stable level of breast tissue. When examining the patient, we look at 3 levels of intervention. That is loose skin, and that's very much what Dr. Hurwitz's article talks about. Then the status of the gland itself, and then the fat content. If the patient is predominantly excess fat in the chest area, then naturally liposuction will work best. In patients with glandular tissue, using liposuction alone would actually be not only inadequate but probably detrimental. So it's very important to distinguish if there is glandular tissue that's part of the problem. And then I explain to patients that liposuction will take out the fat. We have techniques to take out the gland and techniques to tighten the skin. In general, the massive weight loss patients are the only ones that will agree to excisional procedures for excess skin. I have evolved from excising the gland through a periareolar incision very much in a similar fashion as to Dr. Blau and his paper has done, to I currently will liposuction the chest area and follow this with a arthroscopic shaver that we use to shave down the gland. A couple of points about this. The gland is very vascular, and there is a tendency for this to bleed. So we try to do gynecomastia treatment, both any liposuction that's indicated, and then shaving, not excising the gland, as the first part of any multi-stage procedure, so that we have the ability to observe them for excess bleeding. We do advocate using this arthroscopic shaver to remove the entire gland for a number of reasons. In bodybuilders, the pectoralis will give them enough shape below it so that you don't really need to leave any gland. Saucerization with this technique is not very much of an issue. And finally, any gland that's left behind will respond if they continue or begin to use steroids in the future, so that we advocate removing basically total gland tissue. Moreover, with the liposuction as indicated, or the shaver for the gland, care should be taken not to hit the pectoralis muscle. This can cause excess bleeding, and it can cause future dynamic contour irregularities if the muscle is injured. In the bodybuilder patient, they will often be using supplements that may include growth hormone, testosterone, anabolic steroids, and there are complications both physically and emotionally related to the use of those products. So the patient should be off of those products as well as any other supplements. There can be weight gain, mood changes, testicular changes. All of those should be you should be aware of. They're also going to be more meticulous in how they want their outcome to be. Since we no longer excise the gland and we use the shaver, I can use the entry point that we use for the liposuction for my shaver, so there's no additional scarring, which is a concern in the bodybuilder patients, particularly if they're exhibiting their physique on a professional or amateur level. In terms of complications, other than bleeding and some contour irregularities because the overdevelopment of the pectoralis muscle, the complications are fairly similar. Mordechai Blau's large report of a series of over 1,000 patients reported a 12% seroma rate, a 1% static contour irregularity and a 7% rate of dynamic contour irregularities. And in his later series of patients, only 1.5% rate of hematoma. My personal experience, which is not as large as his, is that bleeding has been the most troublesome problem. What should be avoided during gynecomastia correction is an irregular step off where you end your liposuction and any injury to the pectoralis muscle. It is important to take basically a subtotal resection of the gland so that there's no recurrence of the gynecomastia. And finally, I like to break the inframammary fold to allow the skin to redrape. So I go below the inframammary fold. The success of the procedure is based on patient selection. And ideal candidates are patients that have a stable gynecomastia that's not changing, that are not on any medications or products that could cause the gynecomastia or products that could cause bleeding, with good skin tone. When their skin tone is not adequate, then you need to talk to them about a resection or the unpredictability of how much they will contract. Patients should be selected and vetted as has been classically described. They should have a period of a year or more of having the gynecomastia and not be on any products or have any endocrine abnormalities that might cause the problem. So in summary, the gynecomastia patient should be examined, whether they're a weightlifter or a massive weight loss patient or just a patient that comes in with gynecomastia, and determined what we often use the term gynecomastia when other things may be going on, such as fat accumulation or loose skin. We need to look at the 3 layers of tissue that can be involved, that is the skin, the fat, and glandular tissue, and treat all 3 as indicated. When we're dealing with pure glandular problems, it is important to make sure that there are no extrinsic factors that are causing glandular growth. And once you decide to operate, a near subtotal removal of the gland should be done to prevent recurrence and to get an even contour.